This podcast is sponsored by Reflex Medical. Reflex Medical specialise in consumables and equipment supply solutions for clinicians in pre-hospital care. Their product range includes advanced diagnostics, syringes, cannulas, defibrillators and everything in between, with a commitment to enhance patient care and healthcare efficiency. With a passion for advancing patient care and safety, Reflex Medical strive to address evolving healthcare challenges, ensuring their contributions lead to improved treatment and overall well-being. Through dedicated research and development, their aim is to shape the future of pre-hospital care with a positive impact on the healthcare industry globally. To explore their range of products and services, see the show notes for further details. Also check out the show notes for a 10% discount code on their products. Many thanks. This podcast is brought to you by Australasian Medical. Australasian Medical offers innovative hemostatic solutions for managing moderate to severe bleeding in emergency medical settings. Their advanced products like Australasian granules and gauze harness chitosan's clotting properties to swiftly control hemorrhage. Specifically designed for healthcare professionals and emergency responders, Australasian Medical's range ensures rapid and effective clotting even in complex scenarios. This facilitates emergency and interventional procedures. Their range strictly adheres to safety standards and also empowers medical teams to address critical bleeding situations with confidence. So Australasian Medical's commitment to efficacy and safety make it the hemostatic solution indispensable to hospitals, clinics and emergency care units, enhancing patient outcomes but also saving lives by stopping bleeding efficiently. Through dedication to research and development, they aim to shape the future of hemorrhage control and make a positive impact on the healthcare industry but ultimately save lives worldwide. To explore their range of products and services, please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome to the Pre-Hospital Care podcast with myself, Owen Walker. In this episode, we're going to look at burnout in paramedics with Liz Thayer. So what I wanted to do is examine the concept and reality of psychological burnout amongst paramedics. So the effect of burnout are estimated to cost over $300 billion annually, with the WHO forecasting a burnout pandemic in the next decade. So within pre-hospital organisations, burnout can generate reduced quality, high absenteeism, increased turnover rates and substandard productivity. In the conversation, we wanted to examine a definition of burnout, also the factors that increase risk of burnout. We're going to look at models of burnout, the symptoms of burnout, and also possible mitigation strategies to avoid this. We're also going to look at some of the emergent themes from the research and much more. So to do this, I have Liz Thayer with me. Liz is an associate professor at Western Sydney University Paramedicine program, and she's also an associate dean for the School of Health Sciences. She was an advanced life support paramedic with Ambulance Victoria for 11 years and included roles such as a clinical instructor and indeed peer support officer. So she's previously worked for Victoria University within the Paramedicine program and at Deakin University in Learning Futures. She's also an active member of the Australasian College of Paramedicine and is the inaugural chair of the ACP Professional Standards Committee. So her PhD was in the physical anthropology, highlighting a continuing passion for anatomical studies, but her more recent research focuses on the field of health education, mental health and paramedicine workforce issues. So just before we crack on with the episode, I wanted to record this episode for a while actually and dig into some of the empirical research, dig into Liz's research actually as to her well-rounded perspectives. But also Liz has got a really unique perspective. She's not only done empirical research, primary research into the area, but she's also walked and sort of lived a career of paramedicine as well. So she's coming from both camps. Her perspectives are extremely insightful and interesting. I do hope you enjoy this wide-ranging conversation with Liz Thayer. Welcome to the podcast, Liz.
Thanks, Owen.
Liz, I just wondered if we could just start before we look at the working definition of burnout, I wonder if we could get you to speak to what the prevailing problems are around the concept of sort of a continually increasing workload placed on paramedics in the contemporary climate.
I think if you talk to any paramedics at the moment, they will explain to you how the workload has just gone up exponentially over the last few years. And as concerning as that is, I think what's really concerning is that it's also starting to come through from the students. So our future paramedic workforce are also starting to question maybe their career choices and consider whether or not that's something they want to go into. And so some of the problems around it are way beyond our control. We all had a pandemic. It was horrendous, and it did horrible things to the health workforce generally. But there are other things that are positive and also contributing to this. So people are living longer, which is lovely, but they tend to live at home with comorbidities, and that means that paramedics need to come to them. And so with less other health services, they might be involved in that a little bit more. But I think there are things that we can do maybe to help alleviate some of the stresses around this. And some of those relate to that paramedicine career. In the past, maybe when I started training, paramedics were all about you just come in, you work for a jurisdictional ambulance service, and you don't have any other opportunities. And now lots of professional organisations all around the world are starting to open up different career paths. Consider things that maybe aren't full-time work, consider things that maybe aren't shift work. And so they're the kinds of things that we need to balance and explore, given that we're really struggling with those prevailing increasing workload problems that we have.
I fundamentally agree with that, Liz, actually. And we were just speaking offline about the disparate and varied career pathways which are opening up to paramedics. And very much a product myself of pivoting into the corporate world and indeed into the humanitarian world. And I think there is real leverage in that, because I think, like you said, it allows you to see a whole different aspects of industry and how different industry works, but also to develop a whole new set of skills and very much extend the ways in which you approach the career and hopefully give back to the career in future. Liz, as we move on, could I get you to speak to a working definition from your perspectives of paramedic burnout for listeners?
So burnout is one of those terms that we tend to throw around a lot. It just makes it into normal conversation, and it's getting towards the end of the week or the end of the year, and people are saying, oh, I feel really burnt out. And I think what they're often talking about in that setting is they're saying they're really fatigued or they're really tired. And it's important to realize that burnout goes beyond just that tiredness. That's terrible, but it's much more than that. And so what I really like to think about is burnout as a syndrome, because I think from a healthcare perspective, that always gives us a red flag that there's lots of things at play. So as a bit of a working definition, burnout is a feeling of being physically, emotionally, and mentally drained. And that's due to stressors at work, so stress within your work environment, and that results in the fact that you can't meet the demands of your job. And so those three parts interplaying together, pretty much what we're talking about when we talk about burnout.
So absolutely, and it sounds like those very much interlock and sort of almost I say complement each other, but it's encompassing. Could you speak to three dimensions of burnout, more so as of how do they compound each other?
So when we think about burnout, it's actually adapted a little bit over time. Started in the early 70s, which always surprises me because it feels like it's been around forever. But Freudenberger came up with this term in the 70s. And since then, those definitions have varied a little bit. Whether or not it is a standalone disorder, whether or not it's a mental disorder, and there's huge debate raging still about whether or not it should be classified as that. In 2019, though, the World Health Organization finally classified it under their ICD-11. And that definition brought together these three different aspects. So the first one is a feeling of being energy depleted, or sometimes we refer to it as emotional exhaustion. And this is very much the first stage. So work's getting too much, there's lots of stress there, it's building up, and little bits of stress are good, but when it exceeds our ability to cope, that's when we have this emotional exhaustion. And so that's stage one, or the first part. That then moves into the next section. And this is when the person tries to cope with these stresses and the fact that they're exhausted by distancing themselves. And so we often talk about that as being cynicism, or the term that I find really powerful is depersonalization. And especially in a patient-facing role, something like depersonalizing your patient, disengaging with your patient, you can imagine how harmful that can be for both the paramedic, but also for the patient. And so the paramedic's doing that to protect themselves, to try and offset those stressors, but it is still having a really negative impact on their work and the people that they're treating. And then that leads us into the third aspect, and that's about reduced personal accomplishment or reduced professional efficiency. And unfortunately, when we think about that, it might lead to the paramedic leaving their job, but just the concept that they're no longer gaining accomplishment through what they do is a really scary concept and something that we should be trying to avoid at all possible means.
Yeah, absolutely. And as we were saying before, these areas do compound each other, and I think feed into each other. But like you said, the cynicism and the lack of, I think, work, the enjoyment at work or work satisfaction is fundamental, as well, as you were saying. You flagged to me before, and it would be great to visit it briefly, but around Stephen DeHart's work on 5 stages of burnout and how they look in reality. It just maybe it is maybe quite a simplified model. Could you maybe just take us through it briefly?
A great model, mainly because it simplifies down from the 12-stage model, which no one wants to extend through. Um, they call it a 5-stage model. The first stage, I don't really sort of agree with it being burnout, because they call it the honeymoon phase, which is what I hope we're all in most of the time when we're not suffering burnout. The honeymoon phase is things like you're satisfied at work, you've got high productivity, you're feeling great about life, you're engaging with your colleagues, and you feel happy going to work. I'm not entirely sure that that should be called stage 1 of burnout, but that's where we're all sitting. Then we move on to some stressors happening. And as we said, these happen. So stage 2, we start to get a little bit of the stress. And at this point, we also start to get a little bit of the physical aspects that can come in with burnout. So we might get some anxiety or difficulty sleeping, maybe a bit of change in diet. And that's due to those stresses coming in. And so now we're starting to get a little bit irritable with colleagues, which is probably not going to be a positive. Then we move into stage 3, and this is occurring over time. And so it's really that longitudinal build-up that we're talking about here. So this is now chronic stress. Getting more of all of those, but this is when we're starting to bring in the emotional aspects. So we're starting to be really cynical about our work, cynical about our partners. We're feeling quite pressured, and we're probably not a particularly nice person to be working with at this point in time, which I think has bigger issues for an organisation, but also for that individual. And so we're not doing our job very well. We're not being good to work with. And then that brings us through to stage 4, which is when we actually define it as burnout. But as you can see, there's been a lot of flags along the way that hopefully colleagues, managers, ourselves has picked up. And so at burnout, then we're isolating ourselves. We're getting chronic physical and emotional concerns. So dietary problems, chronic headaches, lots of anxiety. We're quite pessimistic about the world. And then stage 5 is habitual burnout. And this is when we're seeing things like depression set in. And this is definitely when people are going to be disengaging from work. So really nasty spiral there, but lots of flags along the way that we might be able to pick up.
So, like you said, it seems to be not necessarily sequential, but very much compounding. There seems to be a perpetual kind of denigrating into more and more symptomatology. So it starts to be there starts to be a real shift in demeanor and indeed in attitude, but also in health. You mentioned some of the symptomatology there, actually, Liz. I guess my question was going to be, could you speak to the symptomatology? But you kind of have. But what I would like maybe to ask is, does it have to be quite linear in this fashion, or can depression come sooner or later? Is it a real mix, or indeed is it quite linear in the progression?
No, I think it can definitely be a mix. I think the other thing is that paramedics are very good at presenting a front to the world. Anyone who does shift work and has to look positive and upbeat at 3 o'clock in the morning learns very quickly how to present a front. And so sometimes it might not be as easy to identify some of those issues. And this is why there is such a big debate going on about, is burnout a mental health disorder or in its own right, or is it the predecessor to a mental health disorder, or is it the subsequent outcome of a mental health disorder? So there's definitely links there to depression, to anxiety, but it's much more complex than just that nice linear path that maybe we described it as.
I think particularly within the health industry and certainly pre-hospital care, I think when there is personal issues going on in your life, it's very difficult to have a forward-facing aspect, or indeed forward-facing persona of care when there is a lot of things you're dealing with, either personally and or financially and or relationship based. It's very hard. It's probably one of the hardest professions to function and to give when there's issues in the background. Could you speak to some of the external and internal etiology and indeed etiological factors for burnout, and maybe what the interplay is?
So this is always an interesting one because they talk about these external and internal factors, and it's always a little bit complicating. I'm not sure that I'm sometimes comfortable talking about them because the internal factors we often link with personality traits. And other than the fact that psychologists are better set to discuss those, I think that can sometimes take us down quite a problematic pathway of suggesting that people with certain personality traits might be more at risk, and that's definitely not the story that we're telling. Burnout is so complex, it has so many different aspects to it that it's not if you have a particular personality trait or an internal factor that you are going to have it. And some internal traits are easier to change than others. To give you a bit of an idea though, when we're talking about internal traits, it might be things like an individual having a really strong need for recognition. So they need that reward and constant reinforcement. And sometimes, as you can imagine, that's not necessarily happening in paramedicine. There are other internal traits that maybe are a little bit more easily amended or addressed. So one of the ones that we often talk about is the individual whose entire life is their job. They don't have any external factors. And I think as much as that might be an internal trait, it's probably one that can be worked upon by the individual by developing that social life and giving themselves a bit more of an outlet in different aspects. And so that's probably a really important one. As far as the external factors go, these are more coming in from work. So things like having lots of responsibility, your manager constantly giving you extra tasks, lack of job or role clarity. And I think this is probably one that in paramedicine in particular, especially with increasing roles, is something that we're going to have to address as those roles change and we move away from just jurisdictional ambulance services to provide some barriers around those roles. Other external factors that often get flagged are the poor teamwork, but it's more about an organisational thing. So it's a combination of the internal, some of which might be easier to change than others, and the external factors.
So just to sort of finish off on some of Stefan de Hart's work, he sort of proposes, him and other authors propose this job demand control model and the effort reward imbalance model. Could you maybe speak to those?
I think they always epitomize health, because when we have lots and lots of symptoms for someone, as health practitioners, we tend to like to put it into a model or put it into a structure so that we can understand it. And that's very much what he's done. And it's important to remember that these aren't predictive models. So we're not diagnosing people through these models. But the nice thing about a model is sometimes you can see a way to provide support. And so these have been developed through the concept of occupational health psychology, which is great because it's not just psychologists, it's not just health practitioners, it's everyone from engineers to public health to health promotion. Everyone's thinking about it together. So here's two models, and there's probably one other model that's also really great for burnout. So the job demand control model. What we're doing here, it's all about balance. We've got job demands on one side, and that's all about your work job demands. So things like deadlines, probably not less so relevant for paramedics, but key performance indicators, how long you're on scene, how quickly you get to your response, what your priorities are, all of those kinds of things. Conflicting pressures of finishing up a job, getting to the next one, and also things like regular interruptions in your downtime. So you can see that there's a lot of demands that relate. And the job demand control balances that with control, which is sometimes referred to decision latitude, but I like to think of it as autonomy. So how many demands you have versus how much autonomy you have. And there's jobs that have really high demands and really low autonomy are at high risk. So that's our first one, the job demand control. Then he also talks about the effort reward imbalance model. And so in this one, effort kind of the same as demands, so all the things being piled in from work. And then this one balances against reward. And when we think about reward, the obvious one we think of tends to be our pay each week or fortnight. But it's other things. It might be promotion or job security, but it can be less obvious things. So it might be getting along well with colleagues or being acknowledged by your colleagues as being a good team player. And again, any mismatch there, we end up with people being at risk. And without being obsessed by models, the final one, which I think is really important because it does impact on burnout, is the job demand resources model. And this is demands still remain the same, but resources are now split between organisational resources and personal resources. So your organisational resources is the fact that your workplace gives you the right equipment, they give you enough staff to work with, they give you the nice ambulance to drive, they give you opportunities, training, etc. Your personal resources then are the fact that you feel skilled to be in that role, that you actually have well-being within yourself, and that you have good relationships, and they might be good relationships at work, but also good relationships socially and personally. And again, then any mismatch between those demands and resources tends to lead to burnout. And I think that one probably encapsulates burnout really nicely.
Yeah, I would agree with you, actually. I was just about to say the same. I think that I could very much picture myself in that model, really. Just like you said, and I've been at both ends of that spectrum, actually, whereby, worked for well-established urban ambulance services in very much in developed countries, such as the UK, London, and also worked across the spectrum in places like Mogadishu, Somalia, and indeed Nairobi and also in Egypt, where it's really extremely different. And I think that has also opened my eyes to what I was indeed initially privileged with. And again, that bias or heuristic that it's, we haven't got this or we haven't got that. But actually, when you compare it in a wider context, you see how other people approach resources and or that and all the demands from an institutional perspective, and how they cope with an absence of resources. But that last model really does. I can really relate to that last model. Liz, I'd like to pivot and look at just a wider question, really, around the implications and problems of burnout, sort of in the wider health context throughout the health service. Could you speak to what you see the implications being?
Sadly, many and varied. I think the first thing to acknowledge is that we're not unique. So it's not just paramedics. I think most people are aware of that, but it is right throughout the health services. I'm doing some research with some occupational therapists, and we're looking at burnout in occupational therapists. So it's going to be all members of the health system. And as far as the broader implications go, it's probably three different layers. So the first is with the individual, the person actually experiencing the burnout. It's going to impact the quality of life, their relationships, possibly their job. They're possibly going to leave their job. And even if they stay there, it's going to be a very negative experience. So we've got a huge personal cost. And I think we really need to remember the individual, even though we talk about it as a concept. The second then relates to the patients and the patients being treated by that person who is going through those stages. They're going to have a poorer patient care experience or a patient journey, and that can have financial implications if they have to then be retreated, but also personal implications. And it could even distance them from the healthcare system, that if they've had such a negative experience, they don't want to reconnect. And then that last implication is an organisational or a healthcare setting. So as we said, like at its most extreme, people are leaving the healthcare system. And internationally, we have health workforce shortages across. We often seem to be pulling graduates from between the UK and Australia and back and forth, and the US now. It takes a long time to train these professionals, and then we have that professional knowledge once they're in there, to unnecessarily lose them. And so not by their choice, but to lose them due to ill health because of burnout has significant impacts on not only the workforce, but then we get into this horrible spiral that those who are left behind have the increasing work demands, and suddenly they're starting to get to the beginning of burnout as well. And so that's a really scary point to be at if we don't actually have some interventions happening.
So we'll look at those interventions. We'll look at the mitigation strategy shortly. We've spoken within the models of burnout around risk factors. Could you maybe speak to your perspectives on risk factors before we start to look at some of the mitigation strategies?
So I did a study of Australian paramedics, and there's a number of tools you can ask people to complete to check burnout. And we used one called the Copenhagen Burnout Inventory, or CBI. And that looks at personal burnout, which is sort of an overall kind of thing, work burnout, how it attributes to work, and patient burnout, which I thought was really interesting. And we surveyed about 1,000 paramedics in Australia. 56 of them were found to be experiencing burnout, which is probably the first concern. But Less so about risk factors. We don't look at risk factors because that tends to be predictive, but we looked at predictors. So looking backwards, what predicted those people to be in burnout? And we found 3 of them. The first was being female. The second was working in capital cities. In Australia, we have large capital cities, but then we go all the way down to rural and remote where you're traveling huge distances, understandably. And the last was having been a paramedic for between 15 and 19 years. So being female it's very mixed in the literature as to whether or not that actually is. A lot of the literature says that females simply express themselves better and therefore maybe articulating that. The other concerns with the female cohort are that they often take on a lot more caring responsibilities outside of the workplace. And so when we think of all of those job demands coming in, there might be more of them there. The other big thing with paramedic research in this area is that lots of it has really skewed data. So there's lots of research going on where the number of females being surveyed is quite small. We had about a 50-50 split in our study. The idea of working in a capital city seems to increase burnout by about 3 times. And we were sort of split in deciding whether or not we were expecting this. Work in a big capital city, lots more work, lots more people there, continuation of work. But you also have a lot more resources. So again, it's nice. You come back to that job demand resource model and you can see how having the resources does actually mitigate. So if you've got the good resources there, you've got support from your organisation. And then the last one was being there for 15 to 19 years. And this was quite different to what often people talk about, people burn out within 7 years or a lot earlier on. So we weren't necessarily expecting this as a predictor. But if you think about it, if you start your career at about 18 or 20 or something like that, 15 to 19 years tends to be when life is happening, when you're juggling a family, young family, partner, mortgages, rents, all of those kinds of things. And so maybe it's more about all of those other demands that's happening outside. And so you suddenly see how complex burnout can be, and especially when we want to interact or make some idea of addressing burnout for people.
Could you speak to mitigation strategies, Liz, if possible, either anecdotal and or empirically proven for listeners?
There is no perfect mitigation, unfortunately. I think the important thing is that it's a collective strategy. So it's a bit like when we talk about occupational health and safety or work health and safety, it's everyone's role. That means that, yes, as individual paramedics, we have a role to maintain our own health, and that includes well-being and a balance of social activities outside the workplace. And so if we think back to those models, that would all support us. But I think a lot of the mitigation also rests with the organisation. And we've seen how many of the job demands will impact there. There are a few things that have come up in the literature that are increasing burnout, and they're things like increasing rates of occupational violence. And so most ambulance services are now doing quite significant campaigns to the public about addressing that. Other things that impact are the issues with our breaks, irregular breaks, unplanned, frequent overtime. That is also something that needs to be addressed. But as you could understand from a management perspective, that would require extra funding and more actual paramedics.
Could you speak to your thoughts on resilience, actually? It was really interesting just to speak with you offline. And I very much actually agree with your position on resilience. It's had a lot of airtime within the current climate, just actually across industry and across different climates, and indeed just within the literature. But could you speak to your thoughts on resilience?
So I'll start off by saying resilience is a good thing. Everyone should be resilient, and anyone who is a paramedic, knows a paramedic, has lived with a paramedic, knows that paramedics are resilient. There is absolutely no way you could be a paramedic without being resilient. Resilience, if we define it, it's about adapting to adversity. And so that's something that is bread and butter for most paramedics. It's about juggling work and shifts and unpredictability. So it's useful and it's something that we have. My concern comes that resilience has been presented previously, and it's a bit less so now, but it's previously been presented as this panacea, the one-stop shop, will fix burnout, just need to fix their resilience. And for something that's so multifaceted as burnout is, it seems unlikely that a single aspect will fix it. And that is the case. And so if we think back to that lovely job demand resource model, resilience is going to help with the personal resources, so the relationships, maybe the teamwork, the social aspect, but it's not going to have any impact on the job demands, on the time pressures, the understaffing, the lack of equipment, all of those kinds of things. And from an organisational perspective, the nice thing is that if they put effort into that, it impacts your entire workforce. But we can't put it all on individuals. And the last thing is that I always feel very uncomfortable saying that someone who is maybe experiencing those early stages of burnout, ascribing blame to them by saying you're not resilient enough. There are too many factors at play here.
So Liz, I wonder if we could just come back to the study, indeed the primary research that you did within Australia and within the 1,000 paramedics. Could you maybe speak to some of the main themes that came out and indeed the results of the study?
So probably the main thing that surprised us and we thought was really important was when I talked about the Copenhagen burnout inventory that we used that looked at personal, work-related and patient burnout. The one that we had that had the least impact was patient-related burnout. And so I think this is important because often that we think of all the traumatic events or critical incident jobs, and the public seems to link those with, oh, that's why people are burnt out. And it's not discounting those jobs. They do leave a terrible mental health scar, but not necessarily the burnout related one. And so we actually found significantly lower levels of patient related burnout. That was the nice thing still at work. It was the work-related burnout that they found a major concern for them.
It's extremely interesting, actually, and like you said, it's very much my anecdotal experience around just the patients weren't necessarily the factor which was stressing me within the workplace. You're right, it was a lot of other aspects as well within that. Could you speak to the climate within Australia at the moment, Liz? What do you see either as an institution or indeed as an individual that's being done within Australia to combat burnout within institutions at the moment?
I think it's two-pronged. It's both at a university level with the training and then at an organisational and the professional organisation level once paramedics are in. And it's probably not specific to burnout. It's maybe a shift in culture around mental health generally, which will definitely help. So it's around increasing the supports around mental wellness, which apply equally to burnout. There's been a shift probably in the last decade with the ability to talk about mental health. We've been very fortunate to have some senior leaders of paramedic services come out and discuss their own mental health journey and normalise seeking mental health as a routine, preemptive support instead of waiting until there's actually a problem. And you can see how that would be such a wonderful concept in those early stages of that 5-stage burnout model. I think as well as that, some of their ambulance services have included mental health or wellness training as part of their mandatory training. So instead of just the clinical skills, it's about the normalisation of it, making it standard practice. And then at a university setting, preparing students prior to them going into their job, I think there's a couple of things that we do. The first is about developing realistic expectations of what the career might actually be. We saw that when we looked at those personal stresses, having an idea of perfectionism or heroism is not necessarily going to set you up for a good and happy career. So I think we have a really important role in the university in training students and helping them understand that so they can have a long career. And then helping them with the strategies to actually consider their own wellness and reflective practice. So it's a whole of system approach, but it's only a very early step and we've still got a long way to go.
So just as we come into land on the conversation, Liz, and also just been the conversation full circle, really, we spoke when we initially started around the concept and indeed the leverage points that are opening up for paramedics just within wider society and wider industry, and some of the adjunctive or adjacent kind of opportunities which are existing now. Could you speak to, as we come into land, just some of the wider opportunities and or strategies that individuals with an individual locus of control could institute to prevent burnout?
I think looking at those personal resources aspect, probably one of the best bits of advice I ever got from a senior paramedic when I was starting out was not to do everything at once. It's very exciting when you start out and you first get your uniform. I think we can all remember that aspect, and you want to do everything. You want to move up to intensive care or advanced care or critical care or try for different roles. And some of the services are quite short-staffed, and so maybe people are moving through quicker than previous. And I remember speaking to a person who'd got onto the helicopter, and that had been what they'd always wanted to do. And they said, once you're there, after a few years, it's just the same. It's very funky and there's a helicopter, but it's just the same work each day. And so I think burnouts, there are so many things from an organisational perspective and they really need to be addressed. But from a personal perspective, balancing your career and where you're going and timing it out. That's really hard to do when you're young and excited, and not something that I've always managed to do. But I think that can actually assist a little bit so that you've got that life outside. You've got those social supports. You've got lots of people who also might identify for you the early flags of burnout. And then when they do identify it, seek help. And that's probably the best.
That's fantastic. Fantastic, and a fantastic place to finish off actually as well. I think what we'll do within the show notes is I will put copy links and or copies of your research within the show notes so people can read further on the subject. We'll also put some of the other authors into the show notes as well, that it was the 5-stage model and some of the other models that we've spoken about, just so that listeners can have a read of those as well. But listen, thank you for that conversation. It's been fascinating and also encompassing, and also just great to get your insights, Liz. So thank you.
Thanks, Owen.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.